Good afternoon, everyone, and welcome to the SAMHSA Center for Integrated Health Solutions, Communities of Practice on HIV and Opioid Use, Trends, Prevention, and Treatment Options, Part 2. The views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, the Health Resources and Services Administration, or the U.S. Department of Health and Human Services. The presenter, Erin Williams, has no conflicts of interest or financial relationships to disclose. We're going to welcome you to the second in our series of virtual COP webinars. This session is the second in a series of 3 30-minute COP sessions that are on-demand webinars. After viewing, please follow the link to give your immediate feedback. Any questions received will be answered by email or by a follow-up TA request based on the session content. The format is designed for maximum learning on your own schedule. And now introducing Erin Williams, who's our faculty who's been leading these COPs. Take it away, Erin.
All right, thank you. So let's talk today. We're going to really talk about looking at treatment for people who have substance use disorders and are at risk or living with HIV. We'll talk more in depthly today about how as an organization, you can begin thinking about implementing services to address substance use for this high-risk population. So let's start today by having a discussion about what we know. So you see on the slide today, talking about assessing the evidence. So folks, as a recap from maybe the last COP, if you didn't see that, folks living with HIV have a higher rates of substance use than the general population. Injection drug use has been known to be a factor for HIV really since the beginning of the epidemic, and also the use of substances is a strong predictor of risky sexual behavior. The use of any substances has a role in impairing judgment, which is correlated with high-risk sexual behavior, high-risk substance using behavior, and can potentially lead to the transmission of other sexually transmitted diseases, which also increase the risk of HIV transmission. So we have a number of elements, moving together as it relates to substance use and HIV risk. Okay, and so when we move forward from that, there's also clear evidence of sound treatment measures to address substance use. And these treatment protocols, when the research has been done on them, they have actually shown benefits around hepatitis C and HIV. So here we have a slide that really talks about the evidence of the use of both methadone and buprenorphine. They are very good medications for the treatment of opioid dependence, which we're really focused on here. And in terms of the results of some of those studies, they've indicated that use of these medications has been significantly correlated with, abstention from substance use in general, particularly opiates, reduction of illicit drug use, other illicit drug use, decreased criminal activity, and also decreased risk for HIV and Hep C. So really thinking about that and thinking about how your organizations can work to reduce their risk of HIV and HIV infections among the client population, really thinking about the use of medications for addiction treatment, opioid treatment in particular, will be a helpful tool as you move forward. So let's talk a little bit about these medications. Our former director of the Office of National Drug Control Policy, Michael Botticelli, had this quote: "We have highly effective medications when combined with other behavioral health supports that are the standard of care for treatment of opiate addiction." And really, that's kind of where we are right now. We have, really good medications, not necessarily blockbuster medications, but medications that can certainly help and assist with people who are, having opioid dependence issues. So when we think about those medications, we have a number of medications, a number of formulations of those medications. Methadone, certainly, which has been around for years and one of the most well-researched medications, on the planet, actually. Buprenorphine, which has now a couple of new formations, the implant and injectable formations, which are on the market now and are very useful, with this medication. Now, Trexone, there's an oral version, but used mostly for the opioid dependence is the long-acting injectable naltrexone. which is the injectable version of that. So we have a couple medications here that are very useful as it relates to opiates. Again, looking at some of the research there, there is significant reduction in incidence of hepatitis C with methadone and buprenorphine. And also extended release injectable naltrexone, it goes by the brand name Vivitrol, as we talked about earlier, also has shown a lot of efficacy in helping people maintain abstinence, achieve medication adherence, maintain retention and treatment. So a number of different things that are really helpful as people move forward and try to move away from substance use. Also, the medications are very helpful in other subpopulations. So if you think about pregnant women, women who are pregnant or potentially in childbearing years, I'm thinking about the use of some of these medications there. Certainly, they've been shown to be very helpful, not just for the mother, but also for the fetus or unborn child. And so these medications, as I said earlier, they are not necessarily blockbuster medications, but they're really good. So when you think about the medications, they're not a panacea, but they're certainly useful. And there's a number of ways in which they are useful. Certainly they're a resource, an adjunct to behavioral health supports, in addiction treatment. They certainly are cost effective, helping clients with complex behavioral health needs. And they really are a supplement to the existing behavioral health treatment. So we're not replacing, cognitive behavior therapy. We're not replacing any of those sorts of behavioral health interventions. We're really supplementing. But when we think about the programs and providers across the country, there really is a slow uptake of the medication. So about 54%, last check, of addiction treatment programs have no physician on staff, so no person with the ability to actually prescribe or oversee the use of these medications. And that's really a critical element to this process, because we have the medications, we have the tools that we can use to really identify, to really engage people, keep people in treatment longer, and really serve them well. But they're not being implemented, as well as they could. So we're going to talk here now a little bit about why you should think about implementing these services and what the benefits are, particularly in HIV care. All right, again, so when we think about what the research says about this, looking at integrated care settings, there certainly is a population that you all are probably serving with a high prevalence of SUD and also maybe at risk or living with HIV. SUDs can increase healthcare costs. Substance use exacerbates other chronic health conditions, particularly HIV and hepatitis C. Substance use can reduce healthcare utilization costs, so people are less likely to actually go and receive the services they need. If you think about these settings, medication-assisted treatment, integrated care settings can really be easily integrated into these integrated care settings. On-site and in-home services are more effective than referral services. That's certainly true. So, the fewer doors you have people go through, the easier it is to provide their services. So if you have the ability to do some more one-stop shop, that is certainly more advantageous in terms of providing services. So let's talk about some of the key components of integrated care. So some of the components for integrated care that really are, kind of the core elements are really screening, using some sort of validated screening tool, which we've talked about in the previous COP webinar. Team-based care, really actually integrating behavioral health services and primary care staff working together. Shared information systems. This is a critical component of this, having the ability to communicate back and forth with communication across provider networks. Use of evidence-based guidelines helps you in terms of standardizing and using these evidence-based approaches. Looking at measurement, review, doing a lot more population health management, thinking about how you can better manage your population as a whole. Integrated care settings allows for that. You can also engage with broader parts of the community. Having both behavioral health staff and other resources available allows you to really engage the community in a very different way to elicit their support. You also have the ability to do person-centered and personalized treatment plans. That incorporate family members, other things that might be beneficial to help the client get well. So let's talk now about some of these core elements to see, are you really ready to implement MAT? So what does that look like? If you have seen the evidence, you've seen the literature, you know this is a beneficial thing, what does this really look like to actually attempt to implement these services? So what we've done here at the Center for Integrated Health Solutions is, through a number of different projects working with the community, we actually developed checklists, a number of these sort of checklist / readiness assessment tools that we think will be helpful in implementing MAT services. So now we have sort of over years, we've kind of refined those tools, and now we've come up with basically a readiness assessment tool, which really looks at these sort of big bucket categories within organizations to assess their readiness. So organizational readiness, economic readiness, workforce readiness, community readiness, and patient and caregiver readiness. So with this tool that you'll see coming up here, really allows you to ask a core set of questions in each category. And you have to, based on your answers to those questions, decide if you are ready to implement in that area, in progress in terms of becoming ready, or actually, not ready at all. So it really helps you as you look through each of these categories, let you know where you are in those categories and what you need to do to begin to become ready to implement. All right, so let's go through these. So I mean, you have this in front of you. You'll be able to look at this, on your computers and download this so you can have it available. So organizational readiness. We have a series of questions here that we gathered from talking to organizations and experts across the country who have implemented, MAT services. Those who have tried to implement and actually it didn't work. We wanted to hear sort of what happened, what their stories were, and what they felt like they needed to do. And other experts in the field to really develop some of these core sets of questions. So organizational readiness, we're really talking about, the top level of the organization. So, is your board of your organization? Many organizations have boards of directors. Are they ready? Do they have enough information to understand what it means to become a provider of MAT services? Do you have an understanding of, your client population and who you'd be serving as it relates to providing these MAT services? Is it everyone? Is it a smaller subset of people? How do you want to think through implementing these things? Do you have the behavioral health supports in place? So really getting a sense of that organizational readiness. So once you've moved past that category, we also have a number of things related to economic readiness. So really thinking about, are you ready in terms of payment and ability to bill for services? And do you have enough knowledge around the financing in order to make this a viable process within your organization? We have a saying that's out there that goes, so the no money, no mission. So certainly you want to be able to provide these services in a cost-effective way, a way that you can continue to do this and offer it for people for a significant period of time. So really these questions are looking at insurance coverage. Medicaid, does it reimburse for the particular medication that you want to use? Is it on the formulary? Are there other ways for you to reimburse and be paid for ancillary services? Other things, are there other testing that you need to make cost? Have you factored that into the process? So really there are a number of different things to think about when you think about this idea of economic readiness. So once you move past that, there is some discussion certainly about workforce readiness, which is a critical component of this. Do you have the right staff, and are they trained in a way that makes sense for you to begin implementing MAT services? Do you have providers who can actually prescribe on your staff, or you have access to them? So how do you sort of manage that process? Do you have behavioral health and other staff who have a good understanding of how to be supportive of this process, which is also critical to this, to your movement in this area. So really thinking about, what do you have in place in terms of actual staff training and support to really support these efforts if you move in this direction. Also, you want to take a look at community readiness. So organizations don't exist in a vacuum. They exist as parts of communities. Really taking a look at, what is your connection to the community? How can you be supported? Are there other organizations that you can talk to, that are already using MAT services? Do you have any relationships with them? Are there other behavioral health providers that you can make referrals to, that you're connected with? So really thinking about where you are in terms of your connection to the community and how you can be supportive of other efforts, and how other organizations can be supportive of you and your efforts. Also, again, critical component of this is the patient themselves, and also other caregivers. Certainly, how is family involved? How are other folks engaged with the client? Do they themselves have a understanding of MAT and what the pros and cons of using these medications are? Do they have a support network that you're available to that is available to them? Are they really engaged in a way that can be supported as you guys move forward implementing these services? So as you think about this readiness assessment tool, again, we wanted this to be very helpful and for you all. Take a second, sort of total up where you are in each of these categories, and it should give you some sense of what you need to do in order to move forward. The information you need to pick up, or the processes and services you need to engage in going forward. So thank you for that. I wanted to make sure that you all had some citations that are linked to all of these different research that's in this particular CLP. So if you just kind of can scroll through that, you can see we have a number of things here that are linked to the conversations that we have. Also wanted to make sure that you can download the recordings and the slides. They'll be on our CIHS website, and you see the link there below. All right, so I want to thank you all, and certainly you can visit us at www.integration.samhsa.gov, and if you want to email us, the email address is there listed for you all. And if you want to talk to me personally, or you have any questions about what was said here in the comments, certainly you can send me an email, or you can give me a call if you want to talk further about any of this. So thank you again, and good luck.